Hello, everyone. My name is Syed Ali, and I'm a fourth year medical student at the Medical College of Georgia. In conjunction with an electrophysiologist at Piedmont Athens Regional, I conducted a study and wrote a case report titled Electrical Storm in a Patient with Brugada Syndrome and COVID-19 Infection. To give a little background, Brugada syndrome is an inherited arrhythmia syndrome characterized by a right bundle branch block and dynamic ST segment changes in leads V1 through V3. Regarding the COVID-19 virus, the severe inflammatory response causes fever in the majority of patients. Fever is also a well-known trigger to induce ventricular arrhythmias in patients with Brugada syndrome. This case report describes the management of electrical storm secondary to COVID-19 infection in a patient with known Brugada syndrome. Moving on to the case presentation, this is a 73-year-old white man with history of Brugada syndrome, known cardiac sodium channel mutation in SCN5A. He's also taking quinidine, and he has an ICD in situ who was admitted to Piedmont Athens Regional found to be an electrical storm. Earlier in the day, he presented to an urgent care facility for dyspnea, dry cough, and a subjective fever for 1 week. He was also noted to have mild nausea and loss of appetite. At the urgent care, he was sent home with oral doxycycline and dexamethasone. Later in the day, he experienced multiple ICD discharges, which prompted him to come to the ED. Later investigation confirmed that these discharges were episodes of VFib. On physical exam, he was afebrile and vitals were stable. He was alert and oriented ×3 and in no acute distress. Cardiopulmonary exam was unremarkable. The initial EKG, seen in Figure 1, demonstrated a type 1 Brugada pattern. There was an absence of VT and VF at the time. PCR testing confirmed COVID-19 infection. The patient was admitted to the hospital and started on cilostazol and quinidine for management of his Brugada syndrome. He was given guideline-directed treatment for COVID-19 infection. Overnight, the patient was noted to experience electrical storm with 4 episodes of VFib requiring defibrillation by his ICD. These episodes correlated with a 1.5 degree Fahrenheit rise in temperature to 99.9 degrees, which is seen in Figure 2. He was given atropine and placed on an isoprel drip to maintain heart rate greater than 90 beats per minute. Ibuprofen was also added for increased antipyretic therapy. Over the next 2 days, he defervesced and did not experience recurrent ventricular arrhythmias or ICD discharges. Keeping all of this in mind, there are a few points I would like to discuss. First, Brugada syndrome is commonly caused by the SCN5A mutation, which is a defect in the cardiac sodium channel, which is seen in our patient as well. Previous studies have demonstrated that the conductance of sodium ions is disturbed at higher temperatures. COVID-19 induced fever is problematic for patients with Brugada syndrome as it increases the risk of potentially fatal arrhythmias. To manage the fever, Tylenol and ibuprofen are very useful antipyretic therapies. Quinidine, cilostazol, and isoprel are useful for prevention of ventricular arrhythmias. So the take-home learning points from this case study include 1. Fever secondary to COVID-19 infection can cause electrical storm in patients with Brugada syndrome. 2. Therefore, ECG monitoring of COVID-19 patients should be recommended to identify life-threatening arrhythmias during initial inflammatory response and periods of fever. 3. Treatment of fever-induced Brugada syndrome should be focused on not only aggressive antipyretic therapy, but also concomitant pharmacological therapy to prevent arrhythmias. Thank you for tuning into my presentation. If you have any questions, feel free to reach out to me via email at syali@augusta.edu.